So, this being said, I was asked to talk about HIFU in 2025. What can we surgeons expect for our practice? How can this improve our practice, and especially the women's acceptance of a surgical, new surgical tool? So my disclosures. So you know that we went from laparotomy to laparoscopy, and now we talk about absolutely non-invasive surgery, which is called focalized ultrasound surgery, with no scar, nothing, and no general anesthesia. So this is a very important evolution. I'm in the generation where we saw the beginning of the laparoscopy, which was a real revolution, amazing new tool. But now there's one step beyond, and it's possible to go further and have absolutely no scar. So why do we ask this question? Because you could think those surgeons are a bit stupid because they are trained, used, they are happy with laparoscopy. So why should we still improve? The answer is here. You see that for when you see the rates of hysterectomy for benign lesions in the US, the mortality is still 150 for 100,000 women. I took the number in France, and it's 20 for 100,000. It's not that we French surgeons are better. I think the patients are not the same, and we have less obese patients. This is the only reason, to my opinion. And you see that morbidity is not nothing, because it's altogether 2,000 for 100,000 patients. So it's an issue for our practice, for everyday's practice. So what is this high intensity focalized ultrasound, this HIFU? What is it? It has been, it's an invention coming from China, and it's an old story because Professor Wang from Chongqing made the invention in 2002, so it's 23 years ago. And as it's 23 years ago, there are many publications, and this is what I'm going to go through for you. It has been approved by the FDA in 2004 and by the European Community in 2010. So you see that it's not quite new story. And there are recommendations from Rudy, who is in the room, who wrote a recommendation for ESGE in 2022, not 2019. And there were the nice recommendation from England in 2019. So what is it? Finally, it's very simple idea. It's converging ultrasound waves focalized on a single millimetric focal point. So it's the same ultrasound as for scanning the babies, for example, but you have two waves, and when they meet, they will destroy the tissue. Sorry for this. So you have an intense and immediate heat generated on the targeted tissue, and the energy is 10,000 times superior to conventional ultrasound generated energy. So the good point is those two waves will travel safely, and it's only when they meet that they will destroy the tissue, because they have to travel safely, because they are not going to cross the bladder, going to cross the bowel, the uterus, and so on. So then you have an hyperthermia, a necrosis, and intracellular cavitation phenomenon. So for a long time there has been MRI HIFU, and now it's ultrasound HIFU. And for many reasons, ultrasound guided HIFU seems to be more economical and more practical, because we all know that depends on the countries, but in many countries you have a waiting list for MRI, and if you are asking to the radiologist, okay, I need one full day next week for the MRI, he will say no. I talked recently, I was really amazed with a colleague from UK, and he said that it was an endometriosis session, and he said that in the UK today, for an endometriosis case, you wait 34 months to get an MRI, you confirm. So it's just amazing. So this is also why MRI HIFU is not a good option. Another reason. So how does it work? The patient is laying face down. She has an IV sedation, but she doesn't sleep. She has to feel the pain, because if you go too far in the posterior wall of the fibroid, for example, she has to say, oh, stop, it's becoming painful. And she has a urinary catheter, which enables to have, you can feel it, you can feel the bladder, so they can move the uterus. So this is the table. you see how it goes, and the HIFU is under, and the two waves are crossing in the body of the patient. So there is a perfusion of oxytocin and also of sonoview, and I will show you what, because it does enhance the visualization of the fibroid. So you see on the left side you have sonoview, you have ultrasound, regular ultrasound, US and MRI. And in the same time you have MRI and US. So this is a video I did when I went to China, to Chongqing, and you see that the operator, the gynecologist, is in front of the screen, and this patient is laying down. She's not fully asleep. It's not general anesthesia, but she can feel, and the nurse is talking to her. And you see this red spot, it's ongoing, so you press on the button, red, it's when the machine is working, red is not working, and so on. And you go all through the fibroid like this. So I told you it's an old story for many countries, and you see that there are 32 countries and regions who have HIFU machines, and there are today more than 400 centers all over the world, of course, mainly in Asia, but also in Europe, also in South America. And it's you see the global number of cases is increasing year after year because you have more and more centers, and you see that 258,000 patients have been treated for benign tumor and 23,000 patients for malignant tumor. So it's not a brand new technique. It's an old story with recommendations and literature. So is it safe? Yes, it is. There's a literature about this. And I did a small video just to show you how safe it is. So you have, you see this little thing for the pap smear, and you see the HIFU is, when you press on it, the two waves are meeting on it. So it does burn. And if you put your hand, it doesn't burn. Why? Because it's only when they meet that it does burn. So you see it's completely safe for the pelvic organs and abdominal organs. Sorry, it's in French. So these are the publications. There's nothing to say. It has been proven that it's much more safe than surgery, for example. And if you take the case of myomectomy, it's 50 times safer than a myomectomy for many reasons, for thromboembolism complication, for adhesions, for uterine rupture, whatever. So what are the indications? We are gynecologists, so for us, it's the main indication is symptomatic fibroids, but also adenomyosis, but also parietal endometriosis, also placenta accreta, breast cancer. We won't talk about this today because it was preservation of fertility, breast fibroadenoma, and ischemic pregnancy. You also have indication for non-gynecologic patients like prostate cancer, liver cancer, pancreatic cancer, and bone tumors. And this is very important because it does mean that when you buy a machine for your institution, for your clinic or your hospital, other practitioners will use it. You will share it with people who are treating pancreatic cancer or liver cancer or whatever. This is very important to take in consideration. The contraindications are the tumor located in air-filled organs and mediastinal tumor and spinal cord tumors. Okay, so let's talk about the fibroid. This is our main indication. You know how often we meet fibroids in our clinical practice. You know the FIGO classification. And of course, HIFU is not for 0, 1, 2, which is still the treatment by hysteroscopy, which is recommended. This is obvious. When you've got a myoma in the cavity, you're going to put the hysteroscope and remove it. That's so simple. But for the others, it's a very good indication. So this is a few examples of the effectiveness of this technique. You see fibroids, single fibroid and multiple fibroids. You see how it works. And there are many, many papers. So I took a quite old one 14 years ago, which was a very important publication with more than 2,000 cases from China and from Oxford. Oxford has been one of the leading teams in Europe with the German teams, of course, and Belgian teams. And there's also another paper published 5 years ago, in the British Journal, comparing myomectomy, and the answer is that it's better than myomectomy. Okay, so adenomyosis is a huge problem in everyday practice because we see more and more young patients who are suffering from adenomyosis, and it's very difficult to treat, as you know, especially when they wish to be pregnant. So it's also working, and there are papers, there are publications about this, there are pictures, and you see that after 4 months, you see this patient on the left part of the slide before HIFU, huge adenomyosis, and on the right part, of course, it doesn't completely disappear. It's not a magic tool, you know, but you still have an image, but the adenomyosis tissue is no more here. It shrinks. So there are papers. You see that 202 patients with 18 months follow-up, and there's a decrease on hemorrhage of menorrhagia and dysmenorrhea. So other papers, paper with GnRH agonist, and also sexual quality of life and sexual life among adenomyosis patients. And this is very important because we have more and more young patients, as you know. So it does work. What's about fertility? When you are treating a fibroid with HIFU, you have no myometrial damage and you have no ovarian damage. This has been proven. You have many papers about this, so it's very important to take in consideration because those patients will have a baby. So what's happening when they have babies? Good point. Worldwide, there are more than 2,500 babies which are born after an HIFU treatment, mainly for fibroids, and there is no complication, no malformations, and no uterine ruptures. So there is absolutely no complication. So which is not the case with myomectomy, even if you're the best surgeon in the world. So there are many reports, a huge literature showing this. So what are the guidelines? The first guidelines have been published by the Canadian Society, and in 2015, it was the beginning of the literature, so they were saying we need more recommendations, more papers, and there are two major guidelines published, the NICE recommendations in 2019, and you know that the English are very strict when they give recommendations. They did a meta-analysis of the literature, and they said, they concluded that it's very interesting because look at this. This is a key message also. The improvement is not one shot. You see 50% of the fibroids volume regress after 3 months, but it's still ongoing process, 66% at 6 months and 83% at 24 months. And there are nearly no complications. If you are trained properly, there are no complications. So it's a very interesting issue. And in Great Britain, there's a reimbursement since 5 years. It's more than £4,000. Okay, and second, and the author is here, and the front row is Rudy Deval. So it was an ESG paper, recommendation paper, taking in consideration the literature, opinion paper, and you see that the HIFU can be considered as a uterine-sparing treatment for women suffering of uterine myomatosis, especially for those wishing to preserve fertility. So especially interesting among young women where you should do a myomectomy. So, nearly, I'm on time. Will HIFU change our practice as gynecologists? I'm convinced that it has to change our practice because we are going on and on in the improvement of our practice. Again, laparotomy, laparoscopy, and now no scar, no hospitalization. So for the surgeon, it's non-invasive. Remember the COVID times when we couldn't access the operating room? We would have been happy to have HIFU treatment because there's no general anesthesiology, no hospitalization, and of course, precise ablation of the lesion and organ preservation. For the patient, there's no scar, no adhesions, no need for blood transfusion. I remember the myomectomy. All the surgeons love this, you know, we're playing, it's fun, you know, you remove a myoma, then you make the suture, you're very happy. But, you know, the uterus is quite weak after, even if you are the king of the suture, and you have to remove it, and you have to suture the uterus. And of course, you don't have a hospital stay with HIFU. The patient is discharged on the same day. And you have, again, no adhesions and preservation of fertility, as it's been said before. The disadvantages is that you have to buy a machine, but again, you can share the machine with other specialists. treating with pancreatic, liver cancer, whatever, and you need to be trained. And the Chinese society, and Rudy can answer the question because he has a huge experience of this. The Chinese society brings somebody with you to help you. It has been estimated that you need 40 procedures to stay alone, and somebody will be with you for 3, 4 months, 5 months till you have done your 40 procedures. So the take-home message is it's a real innovation. It's outpatient, non-invasive procedure. It's really efficient for fibroids, and we all know that fibroids is a major issue for women, especially for young women reaching a pregnancy. It's very interesting for adenomyosis patients, and we all have to say that it's a nightmare to treat young patients with adenomyosis who wish a pregnancy, because you cannot give progestogen, you cannot give IUD because they wish a pregnancy. And of course, the pregnancy is possible, and there are international recommendations, NICE and ISWHR. So thank you so much.
Thank you so much, Dr. Philippe.